ಇದಲ್ವಾ ಇದಲ್ಲಾಗ ಇದು ಮ್ಯಾಕಲ್ಲ ಹಾಕಕ್ಕಾಗಲ್ಲ. ಇದಾ ತಗೊಳ್ಳೋಣ, ಮ್ಯಾಕ್ ಸೆಟ್ ಮಾಡ್ಕೊಳ್ಳೋಣ. Yeah. Good evening, everyone. At the onset, I would like to thank Manjunath for giving me this opportunity. I am not I have big seniors here. My knowledge is very limited. It's learned from teachers, listening lectures from my MD days. So I've been given a topic which is basically on diagnosis of pneumonia. I'll try to do justice with what I know. Not gone into depth in all the details in molecular level. Manju was actually expecting me that, but I somehow didn't feel it was relevant. I just touched where was needed. We can always have a discussion on this. I bring greetings from Indira Gandhi. This is my institute where my third alma mater. First is my Bangalore Medical College. Second is Indira Gandhi and then PGI. My outline would be just a brief understanding and interpret some microbiological tests, some imaging modalities which I would touch upon, and some future tools for pneumonia. So the burden of pneumonia, which you all know, is quite huge. We have like 1.2 to 1.3 lakhs of deaths per year. There's one death every 4 minutes. There's about 50 million cases. This is the UNICEF data, 2017. Even the 25 National Census Guideline also gives this. India contributes to a great number, 10 to 11% of global deaths throughout the world. Major risk factors being, in any resource limited setting, malnutrition, pollution, and delayed care. So we all know, like there's a beautiful lecture by Dr. Nagesh. She's enumerated all the various types of pneumonia. The virus dominate the incidence, but bacteria dominate the mortality many a time. Streptococcus pneumonia still remains the main person, and we cannot go away with it. Like how we have Acinetobacter baumannii sitting in all our ICUs. Baumannii is always there. So Klebsiella, Acinetobacter, and Pseudomonas. We fight with them every day. Like that, Streptococcus is there for the pneumonia part. Etiology is age dependent and setting dependent, definitely. And always consider mixed infections and any resistant organisms in PICU. What armamentarium do we have? Basically clinical. I would always stress upon clinical. Clinical, nothing can match clinical. Like Sir was telling, the high index of suspicion matters a lot in picking up other things. If you send a CBC for a pneumonia, thinking it's PUO, you will not even look in that direction. You will look into enteric, you will look into something else, I feel. So you must have thought of it like one of my commonest causes. That's very, very important. So the core diagnostic features which WHO already stresses, and my senior colleagues have already spoken, is any cough with or difficulty in breathing and fast breathing. You should think of parenchymal involvement, lung involvement. I would just say that. Basically, we generally teach children saying that airway disease is cough. Tachypnea, fast breathing, is more of parenchymal disease, at least when they come to the ER. So when we ask history, ಕೆಮ್ಮು ಇದೆಯಾ ಇಲ್ಲ ಉಸಿರಾಡ ಕಷ್ಟ ಇದೆಯಾ ಇಲ್ಲ ಹಾಲು ಕುಡಿತಿಲ್ವಾ ಜನರಲಿ ಕೇಳಿದ್ರೆ ಕೆಮ್ಮು ಜಾಸ್ತಿ ಇದೆ ಅಂತ ಇದ್ರೆ ಮೋಸ್ಟ್ಲಿ ಏರ್ವೆ ಸೊ ವೈರಲ್ ಇನ್ಫೆಕ್ಷನ್ನು ಬ್ರಾಂಕಲೈಟಿಸ್ ಆಗಿ ಸೆಕೆಂಡ್ರಿ ಆಗಿರ್ಬೋದು ಅಂತ ಎತ್ತಿದ್ದೆ ಒಂದೇ ಸರಿ ಫಾಸ್ಟ್ ಬ್ರೀತಿಂಗ್ ರಿಫ್ಯೂಸಲ್ ಎಸ್ಪೆಷಲಿ ಇನ್ ಸ್ಮಾಲ್ ಬೇಬಿ ಅಂದರೆ ಪ್ಯಾರನ್ಕೈಮಲ್ ನ್ಯೂಮೋನಿಯಾ ಆ ಮಗುನ ಮಿಸ್ ಮಾಡಬಾರ್ದು ಆ ಮಗುನ ಅಗೇನ್ ರೀಎಕ್ಸಾಮಿನ್ ಆ್ಯಂಡ್ go about anta we usually teach our children. So age specific cutoffs, you all know this, I will not go into detail, but at any point of time this work of breathing is increased, baby is uncomfortable, making difficult noises, keep lung as your possibility there. So additional symptoms which you can generally pick up, cough may be there but it may be absent in neonates, you may have to, or small infants. We see a lot of SAM children, we see B12 deficiencies, so you may have to think without cough, just a tachypnea, just lethargy, just fever can be there. Fever may not always be present, especially more so in atypical pneumonias. Fast or laboured breathing is more dangerous. Once when I was in Bangalore Medical College, I admitted a child to GE ward. Child had loose stools. Uday Kumar sir, my teacher, I think you all know. I was on duty, he was a staff on duty, he came and saw the baby. Sir, ಒಂದು ಅಡ್ಮಿಷನ್ ಮಾಡಿದ್ದೀನಿ ಜಿ ವಾರ್ಡ್ಗೆ 4-5 ಸರಿ ಬೇದಿ ಆಗಿದೆ. He came and saw, baby was grunting. It was in respiratory failure. It was doing, and there was a parental diarrhea, what we were taught at that time. And I was absolutely opposite. Put it in GE ward and we had forgotten in BMC. So grunt, respiratory rate, those I can never forget that grunt. So that's always there, which is very important. So signs on examination, you can have tachypnea, which is the most reliable sign. Most reliable sign is tachypnea. Reduced air entry is of course there, bronchial breath sounds, crackles, wheeze. So clinical way is to, one of the ways to diagnose pneumonia is all this armamentarium which we have. Signs of severe pneumonia we all just went through. You can have indrawing, you can have nasal flaring, you can have grunting, you can have hypoxemia, you can have general danger signs, all this inability to feed. Would say again, even if you just get persistent vomiting, inability to feed, I think we should still keep it as a differential diagnosis. In addition to the diagnosis which Indira Gandhi PG scheme. The first diagnosis Indira Gandhi PG scheme, can anybody tell? My PG knows. I always keep telling in rounds. What's the first diagnosis my PG makes in ER? Exactly. IEM. Anything, sir, is IEM, sir. Inborn error of metabolism. Anything. They will send CBC later, but they will send card test for IEM first. TMS first hoಗ್ಬಿಡುತ್ತೆ, IVG ಬಂದ್ಬಿಡುತ್ತೆ, antibiotic ಕೊಟ್ಟಿರಲ್ಲ. ಕೊಡೋಣ ಸರ್, ಇನ್ನ
incidence is very high in your
No sir, I have been there from past 12 years and maybe 10 or 15 pick up ಮಾಡಿದ್ದೀನಿ sir. IEM ಅಂತ diagnose ಮಾಡಿ ಕಳಿಸಿದ್ದೀನಿ. I asked my PGs, each of them would have sent 50-60 in their 3 years of IEM.
ಮಾಡ್ಕೊಳ್ಳಿ, ಅಸ್ಡೋಟಿಕ್ ಬ್ರೀದಿಂಗ್ ಇದ್ರೆ ಆರ್ಗ್ಯಾನಿಕ್ ಎಸ್ಡಿಎಂಎ ಮಾಡಲಿ ಬೇಡ.
ನಮ್ಮ ಹುಡುಗರು ಹಂಗೆ ಮಾಡಲ್ಲ ಸರ್. Anyway, any lethargy, 3rd degree, 2nd degree consanguinity, IEM goes in. So I am asking not to think that. So how do you think viral bacterial? I will not go into this detail. This slide is already dealt in, but it was given in Lancet, so I thought it looked like a useful slide. I will talk about this in different again. The red herrings, which I keep saying, is IEM, definitely. DKS, yes, we can miss DKS. We had once referred one in Bowring only. We referred child as distress and pain abdomen and acute appendicitis to ER. ಎಮರ್ಜೆನ್ಸಿಗೆ ಹೋಗಿ ಅಲ್ಲಿ ಸಿ ಎಮ್ ಕಾಲ್ ಮಾಡಿದ್ರು, ಏಯ್ ಶುಗರ್ ಜಾಸ್ತಿ ಇದೆ, ಬಂದು ತಗೊಳ್ರಿ ನಿಮ್ಮದೇ ಕೇಸು ಅಂತ. ಸೊ ವಿ ವೆಂಟ್ ಅಂಡ್ ಟುಕ್ ಇಟ್ ಬ್ಯಾಕ್ ಆ್ಯಂಡ್ ಇಟ್ ವಾಸ್ ಡಿ ಕೆ, ವಿ ಹ್ಯಾಡ್ ಮಿಸ್ಡ್. ಸೊ ದೀಸ್ ಆರ್ ಆಲ್ ಒನ್ ಮೋರ್ ಚೈಲ್ಡ್ ವಿ ಹ್ಯಾಡ್ ಸೆಂಟ್, ಐ ಥಿಂಕ್ ಮೀ ಆ್ಯಂಡ್ ರಾಮಚಂದ್ರ, ವಿ ಹ್ಯಾಡ್ ಸೆಂಟ್ ಟು pain abdomen. We had sent into trauma saying acute appendicitis. They called me and said it is TBM. Child had appendicitis, mesenteric adenitis with TBM, and we had missed the whole diagnosis itself. So we've done all this. We have walked the path of full of mistakes and landed up here. Anyway,
any sick child should
absolutely right, sir. Absolutely right, sir. That is why in the triage classification in disability, RBS is always there. It's PALS guideline. It's very, very important. Low or high should be treated. DK, of course, can present only with tachypnea, fast breathing, unknown, especially first-time presentations. We haven't seen infantile DKs, 3 months, 4 months we have seen. Foreign bodies, yes, can be missed. We had one child who came only with respiratory distress, and mother didn't give a history of foreign body. But on asking later, we were intubating, we saw 2 arachnoid pieces, we intubated the baby, pushed it in, intubated, took up for OT later. But then we found out this child used to go to the neighboring house. The neighbor used to give 1 arachnoid piece for him to eat when he was taking. And this child had accidentally swallowed and came with a pneumonia neck picture. If the diagnosis was pneumonia, were referred to us. CNS lesions, raise ICP again, space occupying lesions, early TBMs can come with fast breathing, tachypnea, posturing. Postictal, again, we have intubated many children because of secretions, postictal, and pneumonia and tube hakbittithi. Though it's not, so that's one thing. Congestive cardiac failure, again, little fluid overload can present more as fast breathing, Krebs, wet lung, but wouldn't be really, you just need to titrate your fluid and give a Lasix dose, it might improve. These are the red herrings which you can think of, but this is more a clinical diagnosis. So a little on laboratory of what I am talking. Generally, these are the basic investigations we would do. We would do a CBC, we'll do a CRP procalcitonin, we do a blood culture, serology for PCR, and emerging biomarkers, such as new biomarkers. I'm not going to detail about each one. It's beyond the scope. It may take.
Are you doing both CRP and procalcitonin?
Slash, sir. Slash. I'll talk about both.
What are the emerging biomarkers?
No, sir. PCR.
Emerging biomarkers.
Biomarkers. There is one. I'll tell you, sir. The last slide on that. So, you all know leukocytosis with neutrophilia. We general guideline, we think of bacterial, lymphocyte predominance in viral, but it's very poorly specific. There's an overlap, lot of significant overlap which we know. So it doesn't help us to differentiate any differential etiology. We can't say high counts is always bacterial. We've seen adenoviruses. We are writing a paper about 40 cases last 2 years. All of them had CRP in hundreds, like sir was telling, and total counts were 12,000, 14,000, 15,000. On the contrary, and most of them progressed for 2 weeks. And at the end of 2 weeks, we had to intubate, and then we gave steroids. We pulled out 2-3 children like that. The STROMY course over the last 2 years, and I think last year adenovirus has not been there. It's very less to us. The acute phase reactant, CRP, this is what sir was telling. If a CRP level of more than 30 does 90% sensitivity, but less than 25% specificity. So true positivity, that means truly picks up true positivity. A cutoff of more than 300 has 90% sensitivity, but the specificity is just marginally increased, 30%. So we can, if it is high, definitely you can say there may be an infection or inflammation going on, but doesn't rule out a pneumonia. Limitations again, poor specificity. There's an overlap both in viral and bacterial. You can see CRP. Best used for severity assessment as an add-on. They have combined these CRP, ProCal, clinical features and PCR and given a score in some studies in America. So those are used for. And a trend monitoring. Trend monitoring, CRP responding to your antibiotics. Yeah, you're online. May not respond. You have to rethink back. Am I right? Is this pneumonia? Is not? Should I restart? Should resistant bug? Of course, the standard thought process comes back again. The same thing for procalcitonin. It's better than CRP. Especially for severity and antibiotic guidance, but again, clinical utility, a 0.25% nanogram per ml has 90% sensitivity but only 25% specificity, and a value of more than 20, roughly 5 times, we usually take a rough guideline, again has only an increase in sensitivity by 30%. So both of these were done in a similar study and they didn't really stress too much on saying high CRP or high procalcitonin is the thing. We have to add on all the other clinical features before we diagnose it. So CRP has moderate accuracy in distinguishing bacterial from viral infections, but its elevated levels are not exclusive to bacterial. That we've got to remember that. And we get referrals saying high CRP, antibiotic beku anta. Sometimes clinically, if you don't have, you could still wait. I think we should do that. PCT, that's procalcitonin, however, shows higher specificity for bacterial, stronger. This is a little old study. This is probably 24. Current, some more newer ones are not so much in favor of procalcitonin now also. I didn't get the right articles, but I did listen to certain lectures saying that we should still not jump and start out procalcitonin as a real marker in PQs because it has a little variation. But yes, current thinking is PCT high, then bacterial is high chance. That's what we say. And when integrated, both proves the sensitivity might increase more. More so in predicting severe outcomes like empyema or going for necrotizing or pneumonias. Blood cultures, again, we send it for all hospitalized children. Like sir said, in ER, it's a rule that we send for every fevers. But if you're only taking pneumonia, which is not complicated, then you need not send. That is what my teachers have taught me. Most of us follow the same thing either. But if in ER, in PICU, you don't know. So you just get a fever, tachypnea, there will be a lot of causes. So we send blood culture as part of our routine culture. Our pickup rate in my institute also is around 14%, 15%. NICU has a better pickup rate, has got about 23% I think in their mortalities they have presented. About 33% is NICU pickup. It varies a lot because how much sample you take, the culture bottle you use, who's doing it, the first APG, how much he sterilizes. So usually sampling is done by the first year, junior most, for the most difficult. The senior will not come, will not write case sheet. So you know all that. I mean, I not tell that. Whereas senior should be doing all this. The sickest child is shifted by the junior most PG, who doesn't know how to intubate also. So this is what is happening everywhere. That is why I think my institute, I may be thinking that our pickup rates for blood culture is not so great. So we don't really depend too much on blood culture for pneumonias. But we send first BAL if you're intubated, or we send for BAL within 48 hours to pick up quickly. Again, it's definitely important if you have a bug going in, child is coming from another hospital, has received antibiotics, and you need it because you'll have some base to know tomorrow the newer bug may come and you can probably work on that to change your antibiotic again, which does come. So the current standard for viral diagnosis is, next thing is PC, your nasopharyngeal swabs and your PCRs. So there are two things. You could do a nasopharyngeal wash or a saline wash, or you could do a swab. Compared to both of them, they say the wash has a better pickup, but technically difficult to do. This was a question asked to me also in my exams. Which is better, you want to do a swab or a wash? By Rakesh Lodha sir himself. And yes, the wash are better. In AIM study also they have picked up more saline wash. They put a NG in and they put a swab down and they flush it, and that washes the nasopharynx and they collect the swabs immediately, or they aspirate immediately. They do that. They have done that study and they have found it to be better yield. But head-to-head comparison, other studies have not shown this. Swabs are good enough provided you do it properly. Many a time, by the time you enter the anterior nares, they are so and fidgeting, and you may not go to the nasopharynx, or even through the oral cavity, the child may not be cooperative. So if not done, you may not be but if you do well, good. But again, the limitation is we don't know if that bug, that virus is colonizing or it's actually causing effect. We do in a season like that. They can come second time, third time, and each time RSV can be growing, each time adenovirus can be growing. We're getting COVID positive, almost 10 cases last 2, 3, 6 months, and I'm getting calls from BBMP saying, COVID positive bandire ಏನು ಮಾಡ್ತಿದ್ದೀರಾ? I said nothing, ಏನು ಮಾಡ್ತಿಲ್ಲ, ನಾವೇನು ಮಾಡೋದು ಇಲ್ಲ. So ಬಿಟ್ಬಿಡಿ, and they are so keen, ಏನಾದರೂ ಮಾಡಬೇಕು, ಐಸೋಲೇಷನ್ ಮಾಡಬೇಕು, ಇರುತ್ತೆ, ಏನು ಮಾಡೋಕ್ಕಾಗಲ್ಲ. So it is there. I'm not going to treat that COVID, although the child has a pneumonia, and it would have had a para-influenza or a meta-influenza or RSV. So we're seeing metapneumonia virus, RSV and influenza as 3 main bugs in our institute from past 2 years, and almost 2 or 3 per month, but they are not causing problem. That's why we really can't jump onto that PCRs. We cannot confirm causality, and viral detection can be seen even in asymptomatic children, which we have seen, and we have struggled with it. That's it. So basically PCRs are used for RSV, influenza and SARS-CoV. Serology, like again I said, used basically started for more for mycoplasma and chlamydia. The limitation is serology takes time to develop. Pneumonia is a very acute condition, and yes, like sir was telling, which I definitely agree with him, that if you are having a dry hacking cough starting late, especially after first week, more so in a 5-year-old, 6-year-old and adolescent, it's mycoplasma, and they'll respond beautifully to to azithromycin. Because of this knowledge, everybody is putting azithromycin. I have stopped putting azithromycin. No, I don't put. I just don't put. It's been a year since I used a single azithromycin. But 2 years ago I was using, and I thought only I knew this. So everybody started using it.
Now you're using doxycycline and Erlevo? If you tell them.
I'm just on PneumoConclave or plain Amox.
No,
I still.
atypical I'm talking about, mycoplasma.
Sir, I'm not seeing so much. I don't know. I have not tried as of now. But I have used erythromycin. Maybe it's working.
And the PCR has it not picked up?
No, sir.
You do a multiplex PCR?
No. No, sir. Azithromycin, mycoplasmas, we had about 8 I think. I think when you were there only, no? They didn't. Very less. But that time there was outbreak in Delhi with Juma Shankar ma'am, even PJ Chandigarh, all of them reported, and even Bombay, Sonu Udani madam, all were reporting. They saw a lot of non-respiratory
We
mycoplasmas.
had an outbreak in Bangalore, 1.5 years.
Yes, same time.
Same hall, I think Srikanta spoke.
Yeah.
He shared all this.
Everybody asked. Indira Gandhi didn't see. Everybody else saw. Supraja saw almost 8 to 10, and Aster saw so many. And they all saw like convulsions. They saw fires.
Exactly.
They saw HLH like picture.
Neurological.
Yes, neurological or more. GVSs were 2, 3.
Yes.
We didn't pick up. We didn't get some.
We saw it in our clinical practice.
Okay. Maybe. Again, the delayed rise in antibodies, not useful in acute decision making, but if you clinically you think, you can definitely use serology. So it's not quite popular to send serology unless you want to pick up mycoplasma per se as such. Okay. Molecular diagnosis.
Sir. It takes almost 1 week to get the report. So
Which one, sir? Yes, sir. Yes, serology is late.
What to wait so long?
That is why, sir, it's not useful.
PCR you get it very fast, right?
PCR, yes, we send to NIV. Sometimes it's late there. We are now having our own PCR. Even then it is 48 hours. Not get fast.
What about Anand? They do PCR?
24 to 40.
I'm not sure, sir. We don't send to Anand. We don't have MOU with them.
24 to 40 days.
I think they give in 24. Private, I think they give in 20.
Private ನಲ್ಲಿ ಬೇಕು ಕೊಡ್ತಾರೆ, ದುಡ್ಡು ಕೊಡ್ತೀವಿ.
That viral panel,
Mycoplasma IgM. It is what?
ಇಲ್ಲ, PCR ನ ಬೇಕು.
PCR.
PCR ಬೇಕು.
for mycoplasma, the ELISA or a serology only they do. Rising titers only they try to demonstrate.
ಆಮೇಲೆ ಪಾಸಿಟಿವ್ ಆಗುತ್ತೆ ಲೇಟ್.
After 5 days.
Molecular diagnostics, PCR, it picks up the bacterial wall or the viral. There are rapid multiplex assays. The advantage is they're highly sensitive, The detection, like I was telling, it takes about 2 to 48 to 72 hours. And limitation is cost and interpretation challenges. You can grow everything that is there, dead, alive. So a little pinch of salt. We should be careful on taking up molecular diagnosis. Yeah, but comforting is if you get a diagnosis and you can tell the parent that you have this. Yeah, so I'm treating it. Although we don't do anything to it. I personally don't feel picking up adenovirus is great when you're not doing it. Cidofovir I've given only for 2 cases. I've not given to anybody. And maybe a couple of them. Most of the time it is symptomatic. Even all the RSVs beautifully come out with their HFNCs. So I'm not sure.
Sometimes it causes more confusion than giving clarity. You know, you get multiple organisms.
True, sir. True. Yes.
So you will have to ignore the report.
It's difficult to convince the parent, and
multiple organisms, higher the number of species per cycle, that is the one culprit.
No,
Yeah.
again correlate clinical. Clinical is really correlate. Again you come back to the
only advantage probably you can tell this children can become wheezers, which I think you were sharing once in discussion, Manju, that adenovirus can cause long-term wheezing, RSVs can cause wheezing. So you can tell the mother like you're going to get some more because next month they're going to come back. Last month they bandidvi avaglu iಷ್ಟು bill ಆಗಿದೆ ನೀವೇನು ಸರ್ ಇನ್ನು ತಿರ್ಗಿ ಅಡ್ಮಿಟ್ ಐಸಿಯುಗೆ ಹಾಕಿ ಅಂತೀರಲ್ಲ. So it becomes really difficult to convince. Illa, we'll tell them no. Visas baratte. You have to be careful. We have to take care. You must come early to us and they will be sort of prepared to 1 year.
You should put them on a budesonide at the time of discharge for 8 weeks.
4 weeks of trial of budesonide is definitely. Yes. Radiology is supportive but not primarily for diagnosis. What does usually X-rays show? We all know there are a lot of patterns. There can be lobar, there can be bronchopneumonias, there can be interstitial infiltrates, there can be complications which we want to pick up. Empyema, pneumothorax. In BMC we couldn't send an X-ray. I don't know if it was same in your time. HMV sir ಯಾರನ್ನ ಕೇಳೇ ಕಳಿಸ್ಬೇಕಾಗಿತ್ತು ಎಕ್ಸ್ರೇ ಮಾಡಬೇಕಾದ್ರೆ ಆಮೇಲೆ ಚಿಕ್ಕ ಎಕ್ಸ್ರೇ ಮಾಡ್ತಿದ್ವಿ. That was useless. I don't know, we used to do it. And X-ray was, and CP Genta was the rule. We couldn't even put ceftriaxone. We were very, very strict. So we learned without X-ray only. And all bronchial breathing, sir used to keep stealth and he used to give it to us. And we used to ask him. Once there were 3 children, and first case he kept, we didn't pick up bronchial breathing. Second case it was bronchial breathing, we all said bronchial breathing. Third case he kept and gave it to us, all of us said bronchial breathing. He said, "Nin tale normal." Ogu. So we thought he's showing, we didn't know. HMV sir, HMV. You remember her? All of us. Sir was professor to me. HM Vishwanath Kumar. So he used to scold a lot. So bronchial breathing again I cannot forget. I still show it to my PGs also. So that should be picked up more than when you pick up the bronchial breathing and then do an X-ray, you'll really feel, yeah, I found the correct side. I picked it up. That should be happiness. And then, of course, complications which you want to look about. Lung abscess, I would just say, they're very sick children. It will come as a bouncer. You will not see anything. You may not auscultate. Sick, fever 2 weeks, not toxic looking. When you do an X-ray, there will be a nice abscess inside. Probably treated with like Taxim O or something and left alone and come to you. So this is from Lancet, which I picked up. Couple of viral pneumonias. This is a Boca viral pneumonia. Boca virus is a bystander and doesn't really do anything, but it can really cause a very fulminant ARDS. When we had one child and we went into ECMO, till ECMO we couldn't pull out. The child died after 1 month. This is a metapneumovirus in a 7-year-old child and Haemophilus influenza. That is the typical pattern. There are more infiltrates here. This X is not come out well. Paracardiac and some infiltrates here, and lot of infiltrates on the left retrocardiac. Again, this is a
Keshav, you have ECMO in Indra,
no sir, this was in PJ. We did ECMO in PJ. Oh sorry, I was doing my it was the central minister's granddaughter, so we ventilated her, which didn't come out, and we had to put her on ECMO. PJ didn't have ECMO that time. We went on a ventricular assist device for the bypass surgery in cardiac ICU. 1 month, she started bleeding pus from the cannula. They were not ready to wean off. She was dead. And then we had to convince them to take this head off. But it was simple Boca virus. They had gone to Thailand for a trip. Parent had come back, came with a cold, deteriorated in our ICU in 48 hours. Oh, it was very bad. This is a pneumonia caused in an elderly gentleman with more interstitial pattern there. So this is one from our institute with severe interstitial pattern, quite bad. So what are the limitations of chest X-ray? They usually cannot differentiate between viral and bacterial. Inter-observed variability is very high. Early pneumonias, they can be normal. Radiation exposure through low, very low, but still repeated use, so use it judiciously. There was one study, I didn't get the reference, long time when I presented in IAP once. They clinically asked about 110 pediatricians in UK, in NHS, and they gave the clinical pictures of all the children, and most of them, 80% made a diagnosis of viral pneumonia. They showed the X-rays, and 30% changed the diagnosis to bacterial pneumonia, and started antibiotic. So again, that was to stress that X-rays do not tell you it's bacterial or viral. Do not do that. Clinical decision is more important. Is what. Yeah. So WHO, that's why, has not given a clinical. It's given endpoint consolidation, no endpoint infiltrates, and pleural effusion. Only 3 things to be described in a pneumonia on X-ray. That is our pathological, which we talk about. But this is the only thing which WHO has mentioned in its classification of X-ray findings. So.
Can you just explain those 3 terminologies?
Sir, endpoint consolidation is consolidation. If there's a consolidation, that is the endpoint to say it's a pneumonia. There is no endpoint, but there are only infiltrates, then you can take it as a pneumonia. You can't say interstitial infiltrates, you can't say bilateral, prominent bronchovascular prominent bronchovascular markings, and pleural effusion. If these 3 are there, then there's a lung involvement, is what WHO has taken it up. For easy understanding. So when I refer to you, I write no endpoint infiltrates, and you'll understand that. There's no confusion that my dilatation, bronchodilatation dilatation is different maybe from yours. That's why we have done this.
You should read the X-ray. Don't go by what the radiologist has.
No.
Because you're seeing the child and
Yes.
you have to correlate.
True,
right?
sir.
Correlate clinically.
Absolutely right.
But nowadays, trust me, radiologist report they don't give the, because now they are experts in MRI and CT. Conventional radiology, horrible reports it is.
Yes.
I have seen so many children, they have got a consolidation in normal X-ray.
Yes.
Phone ಮಾಡಿದ್ರೆ ಇಲ್ಲ ಸರ್ ಅದು ಅದೇನೋ shadow ಬಂದಿದೆ ಸರ್ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು. True pneumonia.
Scapular shadow.
It's very deteriorated.
So in this study, actually, this was in a pretty old study. Most children with alveolar pneumonia, especially those with lobar infiltrates, have laboratory evidence of bacterial infection. And interstitial infiltrates are seen in both viral and other pneumonias. So they have done both CBC, CRP, and they've combined everything, and they concluded that's why radiological findings are not strong for any particular bacterial or viral. A little on lung ultrasound, which is what we love now. We are doing it like anything. We have machines, and it's easier for us. Most of my fellows are more comfortable doing lung sign, picking up shred sign, rib shadows, then A lines, B lines, aerated lungs, which can easily picked up in the lungs with effusions also. And that's a pleural line there, the rib here and the shadow casted, and the confluent B lines. The A lines would be more, they are reverberation artifacts of the pleural lines. And this is very easy, we can do repeatedly, we can demonstrate also, and I think this has helped us. And Indira Gandhi again.
Confluent lines is pneumonia, right?
No sir. They're prominent B lines, just fluid.
The consolidation is how
Consolidation is the shred signs here. So it will be like as the longest tone. So we focus on that point, and we put a color Doppler. There will be a lot of blood vessels coming all around. It will not come in the normal parenchyma. Yeah, it will not come in. So that's a very strong sign. Yeah, here, this part. Shred sign.
it shreds.
This is your rib shadows, and here this part of the parenchyma is toned there. So it looked like as if somebody scratched and toned like that. So you can typically find subpleural consolidations, air bronchograms, B lines, and of course you can monitor them for therapy, emerging fluid, putting ICDs, pneumothorax. It's very useful, staphylococcal pneumonia now.
Inter-observer variability. You didn't have very experienced pulmonologist.
No sir, yes true, but these are very simple way to do, not a complicated probe. So most of my first years only do this. We have trained them, so it's easy for us to pick up, because X-ray if you call, like he might come, he might not come in Indira Gandhi. Yeah, yes, because he's on leave, today is half Saturday, shift ಇಲ್ಲ ನಾನು ಬರಕ್ಕಾಗಲ್ಲ, wheel ಮುರಿದೋಗಿದೆ, lift ಮುರಿದೋಗಿದೆ, ಏನಾದರೂ ಒಂದು reason ಕೊಡ್ತಾರೆ. She knows, and we fight, and there's one technician on duty for the whole hospital, especially on second Saturday or on Sunday. So we are relying more on picking up pneumothorax on this. I tell my PGs to put ICD, or don't even break your head. You have a desaturation on 20, put ICD, then we'll take it out. No
Keshav, just for my understanding, see, between the two, X-ray and the ultrasound, can ultrasound first came out?
Yes.
then VATS ಎಲ್ಲ ಮಾಡಿ the child now is still in ICU. So ಅದರಿಂದ ನಾವು
Those things can be picked up, sir. Your debris, floating debris, shed side, very earlier than this. Yes, we can pick up.
But ಅದು ಕೂಡ experience to
Sir, any average skill, I think they can.
average ಅನ್ನೋದನ್ನೇ ಒಂದು ದೊಡ್ಡ
ಅದು ಆ ಮಾತು ಬೇರೆ ಸರ್. Averages become below average.
common sense is
Not
uncommon.
all common, sir.
Uncommon.
Very uncommon.
A little on the CT scan. So scan, again, we don't do CT scan routinely, but we do for complicated cases, non-resolving cases, or of course ENT will always ask, or surgery, if you're going reference, they will always ask. On CT ಮಾಡ್ಕೊಳ್ಳಿ ಆಮೇಲೆ ICD ಗೆ. So I don't know why they ask. But you can definitely pick up necrotizing, you can pick up lapses, you can pick up early bronchiectasis changes, you can pick up non-resolving pneumonias, and more so in immunocompromised child, you can pick up GGOs, ground glass opacities. I'll show you a film on that. And detailed anatomy can be used. You can even pick up some foreign bodies sometimes, forgotten foreign bodies, narrowings, and this of course is a lung abscess with an air shadow there. And this is one of the. This is a necrotizing pneumonia in our institute right now. This child with lot of necrotization here and fibrous band all over. Not on vein.
Isolated in organism?
No, sir. No. I've not done. I'm not. I don't remember. I don't think I've done well on this. I think I should do it. This is another case with the interstitial pneumonia with more of GGOs.
How commonly you isolate strep pneumonia in your
Not
strep
much.
pneumonia?
Not much.
Not
Because we are already in Bomani. We got Klebsiella. We
You're
get.
already advanced there.
Yes, we are very advanced with fungus. I did a particular ball for 2 weeks ago. We picked up only Candida, cruzi, so parasilosis. So that is what we are seeing. Okay, MRI and virtual bronchoscopy. MRI is very less, but trend is going towards MRI. Most of my seniors, my Sunil Singh sir himself is saying, Avi, you should do CT scan ginta, you should do MRI in PICU because it gives you better delineage. Why are you doing so much radiation?
No radiation.
Yeah, 100 X-rays roughly. So why do you want to do? And we have not followed up these children for oncological in 30, 40, 50 years. We don't know how many of these PICU graduates are getting cancers. How many are getting Hodgkin's? We don't know. So I think we should still be judicious. But MRI is tough. Sedation, airway problem. But if you can get it done, it's nothing like it. Virtual bronchoscopy is a CT-based one. Based on the slice of the CT, you get the airway delineation. We use it for foreign body evaluation or anything else. So chest X-ray first line, but not always needed. Lung ultrasound, yes, powerful tool. CT reserved for complications and non-response. Imaging supports, not replaces clinical diagnosis. And emerging host, like there are host response biomarkers. There's combined immune markers, which differentiate better than CBC, WBC, or clinical prediction scores called bacterial pneumonia score. So this study, I'll just use this word. It's called transcriptomics, where whenever the inflammatory cells gets exposed to an organism, the non-coding regions of the RNA start producing certain proteins. Now they are typing these children and looking at the pattern of, say, influenza, what type of transcriptomics can be there. That is compared with a normal child. And if this child has, you can pick up pneumonia very early, even though you don't have clinical signs. This is what they are. This article is given the myths and facts. It's a little old article, but it's 19, but it's a quite interesting article. It shows on this.
New generation ಮಾಡಬೇಕಾ NGS ಮಾಡಬೇಕಾ ಇದಕ್ಕೆ whole exome
Whole exam, sir. Non-coding region ಮಾಡಬೇಕು, extended ಮಾಡಬೇಕಾಗುತ್ತೆ. Exam sometimes does only the coding regions. You should go for the non-coding and do it. It's a little costlier, like LLM models, like large lung sequencing ಮಾಡಬೇಕಾಗುತ್ತೆ. But if we have a database of saying adeno is like this, influenza is like this in future, you take the ball of the child or the serology of the child and compare it with that, and if it's positive, you can say this is probably influenza, even before all the features come in suspected case. They're even trying to map normal adults and give patterns of normal healthy adults of various stages. That's what transcriptomics is coming up. This is an additional new thing which I thought I'll just share with you. And my take home is community acquired pneumonia is the best diagnosed using all three modalities: clinical, hematological and radiological. Knowing limitations of each modality is helpful in planning decision regarding antibiotics and future care. Thank you.